Right. First of all, how many of you managed a patellar dislocation? Put your hands up. Probably about 25%. No one's had a patellar dislocation. Ah, there you go. I thought there's usually one. In 30, there'd probably be one.
All right.
How many of you had? Are you all right to talk about it?
Yeah,
I don't want to put
you playing rugby. One time.
One time.
Fine afterwards. Yeah.
Fine. Okay. Good. Right. Look. So in terms of patellar dislocation, tell me what happened afterwards. It should be running. Tell me what happened afterwards whilst this is running.
So I was in a scrum, standing on one leg, and twisted my body.
Yeah.
And just had a big pop.
Oh, a bit like that.
Significant swelling. Couldn't walk.
Yeah. Did you know it was dislocated at the time?
No. I thought I'd dislocated my knee or torn my ACL.
Yes.
Slowly got better.
Yeah.
Sometimes it feels.
Okay, so look, that's a classic story, right? And actually, don't be dismissive of the fact you don't always know it's a patellar dislocation. ACL, differential diagnosis. I've certainly thought something was an ACL, was patellar dislocation, and vice versa. And then sometimes, what's the incidence of the two together in the literature? Between 10 and 20%. I'm not sure it's that high, but some papers have said up to 20% you get patellar dislocation. Right, so it's quite daunting when you've got all these terms thrown at you, like TTTG, trochlear dysplasia, MPFL, osteochondral, all these things thrown at you, femoral antiversion, and you think, oh my God, how am I going to put it all together? Okay, so that's what I'm going to try and do, give you a simplistic, it's what I do in clinic, a simplistic way of trying to put it all together, okay? Immediate management, big hemarthrosis, as long as you do it aseptically, if they're really, really uncomfortable, the most effective thing you can do in terms of analgesia is to aspirate. Okay, but it needs to be done obviously aseptically. You don't want to do it with a recently qualified FY2 as a casualty officer. Okay, so it needs to be done properly. If it's not that swollen, you don't need to do anything. Now, the guidelines have changed. We used to put them in a brace. There is no indication for brace, and I've certainly changed from that. I think if they're really, really uncomfortable, you can put them in a brace for a week or two, but you get them moving, okay? And then a 4-phase rehab protocol. Manage swelling, get back strength and range of movement, coordination, return to play, okay? So, next, in terms of management and assessment, you've got to go from the top down. Okay. Who knows about hip antiversion? Does anyone know? Anyone done a hip job? So you have to assess the hips first. Does anyone want to talk about hip antiversion?
In increased femoral hip antiversion that causes a rotational profile abnormality and therefore can predispose to patellar maltracking.
Yeah. Any idea how you assess for it? Do you assess for it in clinic?
Yeah, so I would position the patient prone and have a look at the both legs, how much it rotates externally and internally compared to the contralateral leg and also within normal ranges.
I'll come back to the other. Any other prone examination?
I'd have a look at the thigh foot angle.
Okay, yeah. So you're doing a rotational profile.
Yeah.
Right, that's really important. Okay, rotational profile. If it's very anteverted, what's higher, the internal rotation or the external rotation?
It falls outwards is how I remember it, so it's the internal rotation.
Yes. So if it's anteverted, you get generally much more internal rotation, almost to 90 degrees, and external rotation maybe slightly. Okay. So you're going to go from hip to the knee, all the way down to the foot. Okay. There we go. So femoral anteversion. Normal values. Anyone got a normal value for femoral anteversion? Sorry? 15, yeah, around about 50, because that's what you might want to put your hip stem in, right? Around 15, right? So 15 is reasonably normal. Definitely above 25 is abnormal. And by the time you get to values of 40, that's really grossly abnormal. Okay, and you don't want to be doing anything to the knee if you've got a femoral neck that's anteverted 40, 50 degrees until back. So what you do is a trochanteric prominence angle technique. So you lay them prone and you feel for the most prominent bit of the trochanter during your rotation, and that will give you a rough idea of femoral neck anteversion. So if you haven't seen it, what is being shown here is that someone's palpating the trochanter and finding out when it's most prominent and what angle it's at. Okay, and that's probably around about 10 degrees of anteversion. Okay. Then you want to measure it radiologically, CT scan. There are lots of different ways of doing it. There's lots of papers about it. There's a lot of variability. You probably want to look at the posterior femoral condylar axis, or sometimes you do a PCL axis. But you want to look at the distal femur and the femoral neck and look at the angle, okay? And that gives you your trochanter, your femoral neck anteversion angle. Okay? Right, the next thing is hypermobility. That's really important. Baton score, everyone aware of the Baton score? Anyone not aware? You put your hands up, don't worry, anyone not aware of the Baton score? Not sure?
I've heard of it, but
okay, who wants to go through the Baton score? Yeah. So what it show the fingers, not quite the index fingers.
Yeah.
Right. So it's
little fingers or
thumb, little finger, elbows, knees, and all the way down. Okay. So that's what you're being shown there. Okay? And there are some very specific values because there's a lot of kids I see say, "Oh, I've been told my kid's hypermobile," and certainly on the Baton score they're not because someone just had a kind of have a half a go. All right. So very specific angles. So for example, little finger's got to be on 90 degrees. So there's your Baton score. This is what you get, and I can't really go into miserable malalignment syndrome here too much, but it's all about femoral anteversion, internal femoral torsion, external tibial rotation, flat feet, all of that. Okay, you've got to look at the rotational profile of the patient before you even get to this bit, right? Which is what I've got there is my finger on the central ridge of the patella. So where's the center of the patella? Okay, and this kneecap is going just about to the center. Now look at this one. That's 2 quadrants medial, 4 or 5 quadrants lateral. So here, this is what I call it a lateral draw. You can call it what you like, okay? But this is really, it's like a Lachman's at the MPFL. It does slightly rely on what the trochlear is doing as well. It's like a Lachman's of the MPFL. All right, and you're looking for an endpoint and you're looking for the degree of translation. And we measure it in quadrants. Everyone okay with that? Okay, next. Then you want to, before you lay the patient down, and I would encourage you to do this in your natural knee examination, okay? You watch them walk and you get them to sit with the knees off the edge of the bed and you get them to flex and extend their knees. Otherwise, in your exam, you might miss these signs. You won't pick them up that easily without, and also, you know, their hamstrings are relaxed, they're doing it actively, you're not doing anything to them. And so you really want to understand where the kneecap is maltracking. Is it maltracking in extension or is it maltracking in flexion? They are very different pathologies, okay? This is not an advanced talk, I won't go through all the different pathologies, but it's to do with MPFL insufficiency, patella alta, trochlear dysplasia. All right. Generally, the extension ones, the kneecap is high, slightly dysplastic trochlear. The flexion ones, it's actually to do with the trochlear and how it's falling off when you're in flexion. Okay. Everyone okay with that? Okay. Skyline views. This is a skyline view, and this shows. Actually, you know, what do you see here? Who wants to go through that? Okay. Abby.
Yeah, sure. This is a radiograph of a patient with a skyline view showing the articulation of the patellofemoral joint. Yeah. Arthritis. That's it. dysplasia of the left knee.
What angle do you think this was taken at? Yeah, the thing is, the tibia's kind of, can hardly see the tibia, so it's probably more like 90, right? This is the same patient taken at 35 degrees. Does this show? So this is near extension, isn't it?
There's evidence of maltracking on the right side.
Left, I would suggest, is worse than the right, but yeah. All right, and that was this patient, okay? So if you are going to do skyline views, in the old days, you didn't get sort of CT scans and different angles of flexion and MRIs. So if you are going to do skyline views, you need to do them at the right angle, okay? Or you do CT scans at different angles of flexion. But really, the clinical assessment is more important than anything.
Compare this X-ray to the previous X-ray. I mean, in this X-ray, I can't see the tibia either. More of the previous one, I can see more.
Yeah.
I mean, because what I'm asking here is like, if we are the clinicians, we don't have that 30-degree flexion written down. How am I supposed to know?
Well, they should be writing it down. If you're really going to do this, these days we do CT. If you're really going to do this, most radiographers, they find it difficult to get these because you then have to position the plate. It's a bit awkward, whereas if you do that, it's easy. But by that time, the patella's engaged. Right, MRI, obviously. Who wants to go through the changes on MRI? There are some there. But what are you looking for in an MRI? Next, I can't keep picking on people I know. So,
You can look at how much articular overlap there is between the patella and the.
which type of slices?
So that would be on your axial.
Okay, so there's your axial. So what you're talking about is articular overlap, or
So if there's like if the cartilage is overlapping between the femoral component and the patella component, that might indicate that there's actually some congruence of that joint versus.
yeah, I think you might be talking about the patellotrochlear index. So this is what we call lateral overhang on the axial. Okay, I think you might be talking about the overlap between the articular cartilage of the patella and the articular cartilage of the femur on the sagittal. That's called the patellotrochlear index. Okay, it's one that we use quite a lot. What else on MRI?
The TTTG
TTTG. So here you are. Here's a TTTG being measured, and this is the central trochlea up at the top. Then what you're doing is you're marking that mark relative to the posterior femoral condyles. Then you're coming down the way to the central of the tibial tubercle, and you're measuring the offset. What's roughly a normal TTTG? Sorry?
Less than 15.
Yeah, less than 15. On an MRI, it's 12 to 15, actually. Certainly greater than 20 is grossly abnormal. There's your TTTG. What about all this? What's this? MPFL. And what's this? Yeah, so really what's happened is the kneecaps come out, like you saw on that original animation, come out, bang this, rip the MPFL at the same time. Sometimes you get an OCD, and then it goes back again. Those are all the changes on MRI. Here is the same patient. This is a ripped MPFL with a small chondral fragment. Okay? Now, so what you're going to do is you assess them. You're going to do a rotational profile. You're going to do the Q angle, which Mr. Carr mentioned earlier, right? Then you're going to look at the knee. You're going to do the tracking with the knees off the side. Then you're going to look at the laxity of the medial structures. Tracking, I often do it with the patient's knee under my thigh, and I get them to extend that. Okay. Apprehension, no one does a Clark's test anymore. Don't do a Clark's test. You literally just see whether that you can translate it laterally, and if they're apprehensive, they usually, what happens is you kind of saw it with that video, tense up. Okay, that's apprehension. And then you might look at and obviously look at the feet. Okay, everyone okay with that? So now we've talked about the pathology. If it's up at the knee, at the hip, you have to derotate the hip with your pediatric reconstructive colleagues. If it's at the knee, you have to decide what are the structural abnormalities. Almost always there's an MPFL if it's a recurrent patellar dislocator. Most patellofemoral instability surgery will involve an MPFL reconstruction. Then you've got to decide, is there trochlear dysplasia and is the tibial lateralized, but not just lateralized, is the patella high? If the patella is high, you want to bring it into the socket, effectively the socket, the groove, okay? So that's how you're going to decide on your surgery. Is the MPFL and tibial tubercle transfer, or is it MPFL trochleoplasty, or is it MPFL trochleoplasty and tibial tubercle transfer? Yeah? What is tibial tubercle transfer? Well, what you're doing is you're taking a slice of tibia, you're going to distalize it and medialize it. More probably distalize than medialize. You're going to, there are different techniques in pediatrics where you're not having to take that. Okay, so here's an MPFL. There are lots of different ways of doing it. Different companies, so Arthrex have got their own stuff. I actually do a transosseous through a proximal distal tunnel in the central mid part of the patella, and we put a we usually put a gracilis through actually, and then you are anchoring it onto the called Shotley's point, which is here. Okay, it is really the flare of the posterior condyle and proximal to Blumensatz's line, that junction there. That is your isometric point in most people. Always use image for that. Okay, and there it is. There are the two strands of the MPFL. Everyone clear about that? So this is pre-op. So what we've done here is an MPFL. You can see the femoral anchor points and the tibial tubercle distalization and medialization. And this is the prostop. You should be confident in you should be confident in flexing that knee if you've got a good fix, okay? Which is why we get them moving, which is why I do transosseous.
What are your restrictions for them post-op?
I put them in a brace, just 0 to 30 for 2 weeks, then 0 to 60 for 2 weeks, and then possibly out of the brace or 0 to 90 for 2 weeks. You want to get them moving.
Are you fully weight bearing them after?
Fully weight. Fully weight bear, but no active extension, because if you think about it, if it's a tibial tubercle, it's the active extension is going to put stress on it.
Do the tubercle first.
Right, so what I do, good question. So what I do is I drill the tunnels for the MPFL, I feed the graft through, I put a guide wire in, but I don't fix the graft. Then I do the tibial tubercle, fix the tibial tubercle, then I fix the graft. Kind of it. So what you do need to understand a little bit is patella position, MPFL biomechanics, some of the kind of insertions of the MPFL. Trochlear dysplasia, anyone know the grading for trochlear dysplasia? De Jour and De Jour have just published a new grading, if you like. To me, right, it's normal, shallow, convex, okay? There's lots of complexity around that, but I keep it simple. Deep, shallow but still cave.